But on behalf of Boulder Community Health, it is my pleasure to introduce this evening's speaker, Dr. John McNeil. Dr. McNeil is board certified in interventional cardiology, nuclear cardiology, and cardiology and internal medicine. After receiving a BS in mathematics from the University of Puget Sound, he earned his medical degree from the Medical College of Ohio in Toledo. Dr. McNeil completed his residency in internal medicine as well as fellowships in both cardiology and interventional cardiology from Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire. He primarily sees patients at Boulder Community Health Center in Lafayette and occasionally he sees patients at Boulder Heart at Community Medical Center in Lafayette and occasionally at Boulder Heart at Anderson Medical Center in Boulder. So it is my pleasure, and help me welcome Dr. McNeil.
Thank you, Wendy. Well, welcome to my talk tonight on peripheral vascular disease. This is my first time doing this web-based format. If you see me kind of looking back at the screen, that's probably because I'm used to my slides being presented up there. But welcome, and I hope you guys all learned something and go away just a little bit more knowledge. Now, many of you probably saw this ad or an ad like this in the newspaper or online asking, is that pain in your leg muscle serious? And the answer to that question is, well, maybe. In order to answer this question, we need to spend a little bit of time talking about the peripheral vascular system, the diseases that involve the peripheral vascular system, the symptoms associated with those diseases, as well as the association with stroke and heart attack. I also included a section on the diagnosis of peripheral vascular disease as well as the treatment options for peripheral vascular disease to kind of round out the talk. Let me see if I can get my pointer up here. So the peripheral vascular system must have been named by a cardiologist because it includes all of the blood vessels with the exception of the heart. So it includes the blood vessels to the head and neck, the arms, legs, intestines, kidneys, and so forth. Here's kind of an extensive list of all the diseases involving the peripheral vascular system. But by far and large, the most common cause is atherosclerosis, fatty plaque buildup, blockages. Those are all the same thing, and they're referring to this atherosclerosis. Now, I kind of highlighted 3 different diseases in here that I want to just kind of spend a minute on, and then we're going to spend most of the time talking about atherosclerosis. The first one is this thromboangiitis obliterans. So literally it means clot, inflammation of the blood vessel, and occlusion. It's also known as Buerger's disease. This one is seen only in people who smoke, and it leads to inflammation of the blood vessels, clot formation, and lack of blood flow. If people quit smoking, this one will actually correct itself. The other one I included down here is iliac endofibrosis of athletes. We live in Boulder. We got many athletic people, and this is a disease we sometimes see in Boulder. So the iliac artery kind of extends from the belly button and then turns into the femoral artery kind of right at the hip flexure. And what can happen is when people are repetitively flexing that hip joint, whether it be running, riding a bicycle, it can lead to stretching of that blood vessel with retraction, and after repeated use, you can get scar tissue, which can narrow that blood vessel and cause symptoms of claudication. The third one I included is more kind of a historical significance. It's just kind of interesting to me, but ergot toxicity. This is what was thought to have caused the Salem witch trials. So there is a fungus that will grow on rye, and it produces a toxin known as ergot alkaloid. And that toxin will actually cause spasm of the blood vessels in the hands and feet and lead to a burning sensation. And so evidently, just prior to the Salem witch trials is a very wet year. Evidently, their rye went away damp, and it was thought that it might have grown this fungus and had ergot toxicity. But we're going to spend the rest of this time kind of talking about atherosclerosis. So on the top of the screen, you can see what a normal blood vessel looks like. It has 3 layers. The innermost layer, which is this black line, is called the intima. It kind of serves as a Teflon coating for the blood vessel, but also releases chemicals which allows the blood vessel to expand and contract. This kind of peach-colored layer is called the media, and that's where all the smooth muscle cells are, which actually do expand and contract the blood vessel as needed. So if you're eating food, you're going to dilate the intestinal blood vessels so you can digest food. If you're running, you'll dilate your blood vessels in your legs so you can do that activity, and that's all controlled by this muscular layer called the media. Then the outermost layer is called the adventitia, and it predominantly supplies the remainder of the blood vessel with nutrients so that it can survive. Now the lower picture, that one is a picture of a diseased artery. And in the diseased artery, the adventitia should look the same. These are slightly different stains, so it doesn't look exactly right. The media, which is the muscular layer, is also going to look the same. But if we look at this intimal layer, we can see a lot of different things have caused it to narrow. So we're going to have fibrous tissue, which would be equivalent to scar tissue. We're going to have cholesterol in this lipid core. And then these green areas are markers of calcium. And what happens is as this plaque forms, it's going to limit the lumen of the blood vessel and limit blood flow, which in turn can cause symptoms. I'm going to skip this next slide. Now, the disease process is the same, but the symptoms are going to be different depending on the blood vessel that's involved. So if we develop blockages in our neck arteries, we can have a stroke or a mini stroke called a TIA. If we develop blockages in our heart arteries, we can have angina or a heart attack. If we develop blockages in those arteries to the legs or arms, we'll get a condition called claudication, or you could also have limb loss. Now this is, let me go back a second. So classic claudication is an exertional pain that does not begin at rest, causes the patient to stop an activity, and resolves within 10 minutes of rest. The way I think about this is the blood vessel's job is to supply whatever organ with good blood supply, nutrients, and oxygen. And so if we pinch off that blood vessel, it will limit blood flow. Now, typically when we're resting, we aren't using our muscles, and so we don't need very much blood flow, and we aren't going to have any symptoms. But as soon as we start exercising and using those muscles, they're going to become active, and if they don't get enough blood supply, we'll get a release of lactic acid, which will in turn cause pain. Now, the pain will progress as you engage in activity and eventually cause you to stop because it's so uncomfortable. And then it will gradually go away because you're no longer needing that much blood supply. Now, since we're talking about the legs, I wanted to kind of point out this slide. So if we had a blockage up here, which is kind of right by the belly button, what we would end up with is buttock pain. If we had a blockage kind of more down here, which is where the hip flexes, then we'd have thigh pain. If we have a blockage within the thigh, then we get calf pain. And if we have a blockage in the calf, then we get foot pain. So the way I think about this is if I was living by a river and all of a sudden the water stopped flowing, I would kind of start walking upstream until I could figure out where the dam was. So if I'm living down here in the calf and I'm not getting enough blood supply, I'm going to walk up, and if I see a blockage here in the thigh, that is where the problem is for calf pain. Now, these are 4 conditions that can cause leg pain but are not associated with atherosclerosis and do not carry that same risk of stroke or heart attack. The first one is pseudoclaudication, and that literally means like claudication. So it's similar to that one we were just talking about, but is definitely different. It does result in pain in the legs, but it is due to a pinching of a nerve in the back. And this one is interesting because it occurs when you're in an erect position. So if you're standing up, you'll get that pain kind of going down into the legs. But if you're sitting down, it relieves the pinching on that nerve and relieves the pain. So people with pseudoclaudication, they're like, boy, I can only walk 5-10 feet and I'm getting pain in my legs, but I can sit on my bicycle and ride forever because that nerve is not pinched when that hip is flexed. These people also will note that if they go into a grocery store and they kind of sprawl their hands over the top of the grocery cart and walk around, they also don't have symptoms. So that is pseudoclaudication and is due to a compression of the nerve in the spine. Now, a lot of people ask me about this one, the nocturnal leg cramps, because that's a fairly common problem and is very uncomfortable. But nocturnal leg cramps are not due to blockages in the arteries. The nocturnal leg cramps are actually due to a nerve firing, releasing chemicals telling those muscles to contract. And so typically when we're walking, we're going to send a nerve signal from our brain all the way down the spine, into the nerve, into the leg. And as soon as that nerve hits the leg muscle, it's going to release a chemical telling it to contract. For some reason at night while you're sleeping, that nerve will fire and set off that chemical, causing a muscle contraction, which is exquisitely painful, but here again, not due to blockages in the arteries. Calf pressure and tightness. This one's a little bit harder to kind of tease out. So this symptom is predominantly seen in athletes. It's usually associated with chronic activity, 6-7 days a week of exercising. It typically occurs after exercise, not with exercise like claudication, and is thought to be due to increased compartment pressure. So all the muscles in the legs are contained within a sac, which we call the compartment. And if those muscles become inflamed or swollen, that sac is rigid and doesn't allow them to expand, and so it can lead to calf pressure or tightness. And so it can be confusing and it can sound like claudication, but this one's typically going to occur after exercise, and it is definitely associated with frequent exercise. The last one on this list is arthritis, and arthritis is easy to separate as well because that's going to be in the joints. So if your pain is in your knee joint or in your hip joint, not in those muscle groups, it's going to be arthritis. And so these 4 things are not associated with increased cardiovascular events. Now, there's a variety of risk factors that can lead to peripheral vascular disease. They're all kind of outlined in this slide. Some of these we have control over, some of them we don't. Currently, we have no control over our genes or no control over the aging process. But all these other ones in this list, we definitely do have control over, and we definitely do want to manage, and I'll come back to that in a little bit. So there's a variety of different tests we can use to diagnose peripheral vascular disease. And the first one is a very simple test called an ankle brachial index. So what we do is we take the blood pressure in the arm, and then we take the blood pressure in the leg with a special Doppler waveform. Then what we do is we create a ratio. So we have the ankle blood pressure over the arm blood pressure or the brachial blood pressure. Now, typically the ankle blood pressure should be slightly higher than the arm blood pressure because the weight of blood between your arm and your leg is going to translate into more pressure. So this ratio should be greater than 1. If this ratio is significantly less than 1, it is going to indicate that we have decreased blood flow going down into that leg. We can also do carotid Dopplers. So we can use ultrasound, the same technology we use to look at babies in the womb, and the blood vessels that are really close to the surface of the body, we can image with this ultrasound technology. Now, the picture on the left side of the screen is of a normal artery, and we can see that the blood flow here would be in red, and that's a nice looking artery. The picture on the right, we can see a pinching or narrowing, showing that that artery is obstructed. We can also use CAT scans and MRI scans to take a look at the heart or all the arteries, and gives us wonderful pictures that look something like this. So the picture on the left, once again, would be normal. The picture on the right would be diseased. What we're looking at here is this is the aorta coming down into the abdomen. Right here would be where the belly button is, and we're going to send a blood vessel down into our left leg and another blood vessel down into our right leg. You can also see the kidneys are highlighted here because they get a fair amount of blood flow. If we jump over to the picture on the right, this is a picture of disease. So we can see the kidneys once again, and then here would be the aorta going into the right and left leg. Now this one, if you look, you'll see something that looks really bright, and then you'll see kind of more of a gray tone. That area that's really bright is calcium deposits. So those calcium deposits I showed you in a much earlier slide will show up white on the CT scan. And the blood is going to show up as this kind of more grayish color. In the right leg, we can see the blood is coming down, and then we see it basically stop right about here, and then it kind of reconstitutes down here at the knee level. And so it's basically blocked from here to about there on this picture. The other way we can take a look at the blood vessels is to do what we call angiography, or pictures of blood vessels, and we do that in a catheterization laboratory. And this is a picture of a catheterization laboratory with the patient on the bed, a doctor, a scrub tech, and a nurse. And we have monitors where we can actually see the pictures we're taking, but the pictures are taken by this camera here. So we inject contrast and we watch it flow through the blood vessels, and we get pictures that look like this, very similar to the CAT scan and MRI that you saw earlier. And here again in the right leg, we can see a pinching or narrowing here where it's significantly diseased. And if we look at this section, it looks like it's dilated compared to this section, and that's not uncommon because the blood flow going through here is going to accelerate in this narrow area, and then when it comes out into this open area, it's going to start creating these eddy currents, which actually cause the blood vessel to dilate. So we have a variety of different ways of treating this disease process. First and foremost is addressing the risk factors. So like I pointed out earlier, family history and age we don't have control over, but certainly we could stop smoking. And stopping smoking is exceptionally important because if you stop smoking, you can actually really slow this disease process down and cause it from progressing. Diabetes, certainly we have many medicines out there to lower sugars and keep those sugars in a normal range, which also slows the disease process. We have many medicines to treat blood pressure, and we have many medicines to treat cholesterol. Obesity, we now have medicines for that. We also have surgery for that. And sedentary lifestyle just requires a little bit of effort and mental fortitude to get out and be active. Now here's a list of medications that are commonly used to treat peripheral vascular disease. The first one, aspirin, pretty much everybody has heard about that one. The second one, Plavix, is a blood thinner like aspirin. It is a glorified aspirin. So those two medicines we use to kind of thin the blood and prevent blood clots from forming where those blockages are. The next medicine is a medicine called silostazol. It also thins the blood, but will also dilate the blood vessel and improve blood flow. So this one is fairly common for peripheral vascular disease, not used so much for coronary artery disease. Pentoxifylline is kind of an interesting medicine. So the blood vessels are these kind of biconcave discs, and they can be kind of rigid as they go through the blood vessel. And when we take this medicine, it makes them more flexible so they get through the blood vessel easier. So it actually decreases the viscosity of the blood. It makes it more like water and less like molasses. Ginkgo biloba, I thought this one was kind of interesting. I have no idea how it works, but there is a study out there showing that if you take ginkgo biloba, it will improve your walk distance before that pain comes on. The bottom one, chelation therapy, so there's a chemical called sodium edetate that can bind calcium, and I did show you that calcium is involved in that disease process, but taking a calcium binder or chelation therapy has not been proven to help this disease process. So here's a couple little jokes on exercise. The first one is Ronald McDonald trying to get shaped up on his treadmill. The second one is a gentleman who's been connected to his TV set via an electric bicycle wheel, and is hoping to lose 10 pounds before the World Series is over. Now, exercise is extremely important for peripheral vascular disease. So if you have blockages in your heart arteries and you exercise and you get chest discomfort, we are definitely going to tell you to stop, because if the heart does not get enough blood flow, it can lead to rhythm problems, which can be life-threatening. But for this peripheral vascular disease or claudication, we're going to tell you no pain, no gain. What happens is when you exercise into that pain, you're going to release chemicals, which is going to tell your body to grow new blood vessels. And with growth of new blood vessels, those symptoms are going to get better, better, and better. They may not go away, but the amount of time you can exercise before they come on would certainly be much less with regular exercise into the pain. Another way we can kind of manage those blockages is with what we call percutaneous intervention. That is basically putting tools in through a blood vessel in a leg artery or arm artery and using tools to kind of open up those blood vessels. We have a variety of different tools that we can use. I've shown 3 of them here, but there are many more that are available. The one up here is a balloon. And so we can pass a balloon across the blockage, inflate that balloon, and squeeze the blockage out of the way. It works really well, but the problem is when we deflate the balloon, sometimes we get elastic recoil and it re-narrows on us. So then we came up with this little device here, which is a stent, and we can mount that over the balloon. And then when we inflate the balloon, it deploys the stent. And now when we deflate the balloon, that stent is left up, creating a rigid framework that prevents that blockage from recoiling back in. This is kind of an interesting technology over here. This is what we call an atherectomy catheter. There's a variety of different types of atherectomy catheters, but this one has a blade right here, and as you push it down, it's going to scrape that plaque down here into this tube, and it can be removed from the body. Now, which one of these tools we're going to use really depends on what we see. So when we go in and we see these different blockages, we're going to choose the tool that does the right job for us. We don't specifically just use one. So this is a case I did a couple years ago, and what we're seeing here is the aorta coming down, and it's going to go into the right leg and then down here into the left leg. You'll see a couple little branch vessels kind of coming off in these areas. Right here you'll see that there's a fairly tight narrowing, and there's also a fairly tight narrowing right here. Now these can be this can be kind of hard for us to manage with our stents and balloons, because if we put a stent in here, we can get what we call the snowplow effect. So if the snowplow goes down the main road, it can throw that plaque or the snow into your driveway, and then you can go clean your driveway and throw that snow back into the main road. So we've come up with a technique for dealing with this, which is what we call a kissing stent or kissing balloon technique. And that's kind of what we did here. So I have a wire coming in the left leg going up. I got another wire going in the right leg going up. And here you can see two balloons being deployed at the same time so that that plaque moves everywhere but those two blood vessels and the blood vessel above it. So I'm having an issue with my movie not playing. Do you have control of it over there by chance?
No, I would turn your laser pointer off and try clicking it.
Okay.
Let's see, is there like a hit button, play button?
Ah, here we go. So this is after we put the two stents in. We're injecting contrast into the aorta. We can see it come down and that this blockage is now much less, and the blockage over here is also much less. So I'll point that out one more time. And then here's another leg artery. This would be the aorta coming down at the top. And then as it comes down, you can see a real tight pinch right in this area. This is kind of what our stents and balloons are ideally made for, because we have a landing zone from here all the way down into here. And so here we're using a balloon to open up this blockage. And then here's another photo afterwards. And we can see how much better this area looks through here when compared to the pre, which is right there. Now, occasionally we can't use our stents, balloons, or atherectomy devices to open up blockages. Typically blockages that are completely occluded or heavily calcified or exceptionally long, those types of tools don't work very well under those circumstances. Not to say we can't fix them, but our success rate starts to decrease. So there's a different way of managing this, and that is with what we call bypass surgery. And so here we can see an artery going down into the leg, and we can see some narrowing within that artery. So instead of trying to go through it and open the main road up, all we do is we tie a bypass graft in and we go around that artery or that blockage. In this next case, I found kind of interesting because it was an example of both stent failure and also an example of bypass graft failure. So I'm going to play this and I'm going to try to pause it and show you something because it's kind of hard to see. So here you can see a stent line that has come down and it's going to continue on down. And then here they've tied a bypass graft in above that stent line and it's coming down and it's going to tie in further downstream. And so I'm going to play this again and then I'm going to show you where the problem is downstream. So here it comes down, we'll see the stent failure. And then we'll see the bypass graft carrying the blood down below the knee. And then right here where this bypass graft ties into the native blood vessel, which is running like this, there's a big pinching or narrowing right here. And this is kind of right down at the ankle. So this is a picture. Let me back up a second. I guess they didn't show the fix, but this is a picture after we fixed it. And so what we can see is the bypass graft is coming down, and then we ended up using a balloon to kind of open up this section so we get blood flow down into the bottom of the foot. And then it's also coming up this way and going over and supplying the top of the foot as well. Now this is kind of the most important slide. which is the peripheral vascular disease related to the atherosclerotic plaque, which causes symptoms of claudication, can predispose to stroke and heart attack. And if we have claudication, the risk of stroke and heart attack is 20 to 30%. So if we are having pain in that leg and it is related to claudication, it's important to address, mostly so we can reduce that risk of stroke and heart attack. So it looks like we have some time for some questions.
All right then. And we do have a few questions. We'll encourage our audience to go ahead at this time and ask some more. But here, let me just type that in right here. All right then. So let me get to the first ones. This guest says that I was taking a statin late last year and had to stop. It really affected my legs. Does this make any sense to you?
Yep. So this one is a great question. So statin drugs are one of the primary therapies we use to treat cholesterol, and high cholesterol is definitely associated with peripheral vascular disease, coronary artery disease. The statin drugs can occasionally cause a condition called myositis or inflammation of the muscles. And so statin therapy can definitely cause leg pain. That would not necessarily be true claudication, and definitely need to come up with a different strategy if that's what is happening.
I see. This guest says, I have frequent cramps in both legs, both high and low, more frequent when sleeping, but it also occurs when I'm sitting in my easy chair. So that's kind of general, but can you offer a little suggestion there?
So I think that's a good question. So when we were kind of talking about nocturnal leg cramps, I was saying, boy, that is not related to peripheral vascular disease. And so we have those being reported, but we're also experiencing while we're awake or sitting in our easy chair. And so that would mean it's not 100% pure nocturnal leg cramps and probably would warrant a little more investigation.
Absolutely. And do patients come directly to you, or are they referred through their provider?
Good question. No, I think most people come to me directly. It kind of depends on insurance. So some insurances want you to go to your primary care provider before you get referred to specialty care. Other insurance companies do not require that, and you can come straight.
I see.
To me.
Excellent. Excellent. All right. Can you please speak to us again about calcium? If a person's able to walk terrain distance without leg cramps, is that an indication, but they still have leg cramps, is that an indication that it's caused by other reasons, like not getting enough calcium?
I thought this question was going slightly differently. So this purely is a supply and demand issue. So if we have a narrowing in that artery, it is going to limit the supply of blood. And it would be kind of like hopping in your car and having your gas line pinched. So the symptoms you're going to expect with this will be exertional or at higher levels of activity. So I would expect if we aren't having symptoms, hiking, walking, running, those types of activities, then boy, we aren't really doing much and we're having it, it probably is something other than peripheral vascular disease.
Excellent. This guest says, and I think others can maybe relate, I had some relatively minor cramps, like twitching in my legs. My primary doctor suggested taking magnesium citrate supplement. I've been doing that, and the twitching has stopped. Is this a form of PAD or something different?
My guess is probably something different. So Trying to figure out how best to explain this. So the nerves in our body and the muscles all require electrolytes. And so we have certain electrolytes that are contained within the cell, certain electrolytes which are contained outside of the cell. And so the cell opens up channels allowing those electrolytes to switch places. And that causes the muscle to contract and do what it needs to do. So if we're having that muscle contracting when it doesn't need to be doing it and getting those twitches, it means those channels are potentially being opened or there's an imbalance in the electrolytes. And magnesium is one of those electrolytes that you need, or supplements that you need to absorb calcium and potassium. And so that was probably why that was recommended.
Excellent. Do you know of any side effects with ginkgo biloba? Taking that, I thought your information on that was very interesting, that can prove helpful. And do you have any amount recommendations, or is that something that is specific to each person?
Yep. So the problem we have here is ginkgo biloba is going to be managed as a food product. It's not going to be managed as a medication. And so when that happens, we don't get the data we really want, because it's going to have the same amount of scrutiny as an egg or your milk. You have to put in it what you say you're putting in it, but you don't have to prove it works. You don't have to look for side effects. You don't have to do dose finding. And so in this case, somebody did do a study on it. I don't remember what the dosage was, but in terms of side effects and other negatives, we don't really have a clear information on that.
What is ginkgo? Is it a plant?
Yeah, it's a supplement.
I see. So I'm getting a lot of questions here about varicose veins.
Okay.
And I just will sift through and kind of, first of all, are varicose veins related to PAD?
Right. So good question. And so I was talking strictly about PAD. So in our body, we have arteries and we have veins. So the arteries would be I-25 south. That's what's carrying the blood down into your foot. The veins are I-25 north, taking that blood back up to the heart. So they're very different responsibilities. So arteries are under high pressure, so a normal blood pressure, say 120/70. That's the type of pressure we're seeing in those arteries. The veins, those are under low pressure, typically 30 millimeters of mercury. So a very different blood vessel with a very different job. And so the diseases I was talking about today are all related to arteries. They do not apply to veins. And having varicose veins does not imply that you have artery problems.
I understand. Okay. All right then. Well, thank you. I think you may have covered this, but this guest is asking if leg cramping at the hip flexor, does that indicate PAD?
Mm-hmm.
It does.
It can. Like I said, I'd want to see it be exertional related as opposed to, sitting down or whatever. But yes, certainly the hip flexors, those are going to be related to blockages kind of more up in the distal abdominal cavity.
Okay. If someone has an ABI, which comes out fine, and PAD has been ruled out, but has horrendous throbbing and cramping leg pain at night, which type of doctor should one go to see to try to figure out what's going on?
Yeah. So the first thing I'd like to point out is an ABI is not 100% perfect, but the fact that that would come back normal certainly puts us into a low risk for this. And then if we're walking and doing other activities and not noticing it under that circumstance combined with a normal ABI would make me think, no, we are not dealing with peripheral vascular disease, and that would be seeing your primary care doctor.
Okay, excellent. Are cold feet and hands symptoms of PAD?
They can be, but not necessarily 100% true. When we were kind of looking, let me go back here, quite a few slides really. Going all the way back to the beginning, which is kind of my first slide, looking at the arteries. So basically, the arteries have this muscular layer, and so it allows the blood vessels to expand and contract as needed. So the body's primary job is to maintain its core. So the brain, the liver, the intestines, all those things, the heart, all those things want to be kept warm, and so the body's going to prioritize blood to those areas. Now the periphery is not going to be prioritized, and so if we are starting to get cold, we are going to clamp down the periphery, and we will get cold hand, we will get cold feet. Now, if we do have pinching in the blood vessels, could that predispose to that? It could, but it does not necessarily imply that that's what is going on. And more often than not, it's actually the blood vessels are fine. They're just expanding and contracting to meet the body's needs.
I see. So I will remind guests, we have a few more minutes for questions, and we only have a few questions that have come in left to ask. So, go ahead and ask your questions now. And there is also this lecture has been recorded for future viewing. If you have a question, you could look back through this video and see if it was answered during your lecture. So this guest has a question. How about what is called sciatica? What is it, and what causes it, and is it related?
Yeah. So it is leg pain, but it is unrelated to the blood vessels. It's actually due to pinching of one of the nerves as it kind of goes behind your buttocks, and then it sends a nerve pain down the back of the leg. Typically, it's going to be fairly localized going down the back of the leg. It's not going to involve the whole muscle group, and it is due to a pinched nerve.
I see. Yeah, it is. That's painful.
Yeah.
Business right there. I have a couple, just a new question here and then another question. First of all, are compression socks useful in treating this pain? This guest here says, I was evaluated for PAD and I wear compression socks at suggestion of vascular surgeon for 3 or 4 years now. Right EIA up to 50% stenosis.
Right, external iliac up to 50. Mm-hmm.
Otherwise, no detective lower extremity arterial stenosis.
Mm-hmm.
I have arthritis and run into joint pain and inflammation. Do I need to be reevaluated for PAD? And often, how often? 2 to 5 years.
Gotcha. So there are many things tied into
Yes,
this particular question.
It's a complex one.
Yes. So one concept I'll point out. So we're talking about a 50% narrowing. And this is one that, struck me odd when I first was learning about the vasculature. And so the blood vessels in our body are predominantly kind of like our water main, okay? So most of the resistance to blood flow is going to be way downstream at the arterioles that we can't even see. And so if we take a look at our water main, most of the resistance to flow is going to be at our faucet where we have these small little valves with small little holes. So typically the major blood vessels aren't going to start limiting blood flow until they get up around 70% narrowed. And so that's pretty severely blocked before we start seeing symptoms. And it's a little bit counterintuitive to say, oh gosh, at 50%, we're going to kind of not do anything with that. The second piece to the question is, should you have regular follow-up? Definitely. Okay, we want to make sure symptoms aren't changing. We want to make sure we're on appropriate secondary prevention. New medicines are coming in, and so that should be a yearly follow-up with vascular surgeon, cardiologist, primary care to make sure those are being addressed. And then the third one, the compression socks. I didn't include it in my slide. They do have these compression devices that they use for peripheral vascular disease. It is not a compression sock. in any way, shape, or form. But what it is it's kind of like the shock trousers that a pilot would wear, a military pilot would wear. And so when they go hit these heavy G's, all the blood wants to go down into their legs. So they have these shock trousers that inflate and squeeze their legs to try to keep that blood up into the head. So they made a similar device, and it will contract and then it relax, contract, and relax, contract, and relax in like second intervals. And that has been shown to help improve blood flow down into the legs. It's not a real common therapy that's used, but there's data out there. But the standard compression socks that people wear are typically for venous issues, not arterial issues.
Right, I see. How does anemia and/or high altitude affect blood flow?
So it shouldn't necessarily affect blood flow. Okay, so what is the job of the heart? It's basically to deliver oxygenated blood to whatever organ system we want. And so if we're anemic, that would mean that we don't have as many blood cells, so we cannot carry as much oxygen. So if we had half the amount of blood, we'd have to double our cardiac output to maintain the same oxygen delivery. So it shouldn't necessarily, it should be more at the heart level in terms of pumping as opposed to the disease, peripheral vascular disease level. The second one would be altitude. So we're here at mile high. Our barometric pressure is probably 630 millimeters of mercury. Barometric pressure at sea level is 760. So we're probably, getting 25% less oxygen molecules per breath. We're still breathing about 20% oxygen, but we get 25% less oxygen molecules in. Typically not a problem unless we have underlying lung disease, because our lungs should have enough reserve to deal with that. It's only above about 29,000 feet where your lungs can't deal.
I see.
Yeah.
I see. So this guest says that she really can't get to Lafayette often. How often are you in your Boulder location?
So can definitely come see me. Yeah, when I'm at Boulder, that one is pretty rare. But my partners in the Boulder location definitely have the skill set to manage this as well.
Wonderful. So this person says, I have leg pain that comes on intensely and then goes away after about 10 minutes. Is this PAD?
Is there activity associated with this?
Maybe if the guest is still listening and they can answer that question. No, it just, no, there's no mention of if it's at rest or exertion.
Yeah. So that would be harder. If it was coming out with exertion, I'd be worried about it. If it's just kind of at rest, probably not.
Oh, okay. All right. So maybe that guest will give us some insight there in the time we have left. So could a total knee replacement have caused arterial damage that leads to leg cramping?
Possible.
All right.
It's just, that's about as much clarification as I can get about that one.
I gotcha.
Yeah, typically you wouldn't expect that to be the issue, but if somehow during the surgery we traumatized an artery that goes behind the knee called the popliteal artery, that could cause calf pain.
Sure. All right.
And I have seen it once before.
This question just came in. So is your heart specialist the one to go to detect PAD?
Yeah, so oftentimes the disease process that leads to coronary artery disease and the disease process that leads to peripheral arterial disease is the same process. Management is very similar for those. And so most of the cardiology specialists feel comfortable managing the peripheral vascular disease. Now, in terms of if we needed to do those stenting and ballooning procedures, to try to open up those blockages. Not all cardiologists do that procedure, and so would need to go to a cardiologist or a vascular specialist that does do those. But in terms of diagnosing risk factor modification, most of that management could be managed at the cardiovascular specialist level.
Right. So back to the question the viewer had, let's say the one with the intense pain that goes away after 10 minutes. They have clarified to say that the pain is when they're standing or walking.
Okay. So the pain with standing or walking could be peripheral vascular disease and claudication. Could also be that pseudoclaudication where we're pinching the nerve. And really the distinguishing factor there would probably need some testing to sort it out. But often if it's pseudoclaudication, if you're bent over, where you're flexing at the hip level and you're bent over, that improves the symptoms. You can find that you can go much further.
Okay. Thank you. All right, let's see. Just speak again briefly to this. How do you know if you have PAD versus onset of neuropathy? If legs exhibit tightness and pain?
So the character of the pain in those is different. So neuropathy has a very different flavor than claudication. So claudication is definitely within the muscle groups. It's pain, it's cramping in those groups. It's definitely associated with exertion, relieved with rest. Neuropathy tends to be more tingling. Some people describe it as hot or burning. And it's not going to be really affected by exertion, right? You can exert yourself, it's there. You can not do anything, it's there. And so the flavor really kind of separates those two.
I see. All right, so this guest says, and we have time for a couple more questions. When they're lying or sleeping on their left side, they develop an ache in the left thigh that gets progressively worse over minutes. And so then they're forced to roll over to the other side, which alleviates the pain altogether. They have no other symptoms, and ache never appears in the other positions or doing exercise. Could this be a symptom of PAD?
Could be a symptom of PAD, a little bit harder to tease out. I'd also be a little bit concerned about could we be pinching a nerve in the back as well with that one. So kind of when you lay on your side and your hips get pushed up, you kind of put some flex on that spine. And if we end up pinching the nerves, it can certainly cause pain in that area.
Yeah, okay. All right. This question is asked twice, so I'm going to ask, how does one differentiate PAD from leg pain due to back or disc problems?
So the back or disc problems is going to be pain that's more like the neuropathy. Okay, it's going to be uncomfortable, but it's going to be nerve pain versus the claudication, it's going to be more muscle pain. Nerve pain, if it's a nerve root, tends to be very localized. So if you have, I forget which nerve it is, but there's one that comes down here, and it would go just like that. It'd be just like a straight band going right down the leg or a straight band going down the side of the leg. That's very localized. And so that's going to be coming from a nerve, where the muscle, it's going to be the whole area.
Absolutely. All righty then, let's see. We do have one more question. I'm going to ask this one, and if we don't, receive any others at this time, we'll just wrap up just a couple minutes early here.
Sure.
So, how do muscle relaxers used to relieve leg and foot cramps work for nocturnal leg cramps?
Don't know.
Okay.
Yeah.
All right. Okay then. So, all right. Well, is there anything else you would like to speak to? I guess.
I'll answer one other question
Yeah.
because somebody asked about the calcium.
Yes.
And this comes up not infrequently. So I just kind of showed, like on this slide, here we have calcium deposits in that heart artery. And so, gosh, should I not be taking supplemental calcium for my osteoporosis because calcium is in this vascular disease? And there was one study done probably 10 years ago now that associated calcium supplementation with coronary artery disease by coronary artery calcium scores. And so the study came out, and most of the experts in cardiology at that time did not believe that that would be the case. When I hear about a study, the first thing I always want to do is, does it make sense physiologically? So the body wants to manage that calcium very, very carefully. And so if we get too low of calcium in our body, we'll actually get tetany. Okay, hypocalcemic tetany, our muscles will actually just freeze. If we get too high of calcium, then our nerves don't work well and people get really confused, disoriented, and it doesn't work well. Typically, you see that somebody who had cancer, had metastatic disease to the bones, then the calcium gets released into the bloodstream. By far and large, the body's going to do whatever it can to keep that calcium at a very specific level. And so if you don't get enough calcium in your diet, your body will go to your bones to get that calcium, to raise the calcium levels in the blood. And calcium is a marker of disease. It's not a cause of disease. So if we think about like tuberculosis, people get tuberculosis, we can see it on a chest x-ray because those granulomas took up calcium. Just like the CT scan I showed in my slide, you could see the calcium being taken up in the diseased blood vessels. So calcium is a marker of disease, it's not the cause of disease.
I understand. Okay, then, well, there is actually a part 2 to the question.
Part 2.
Part 2, I think we have just enough time to get it in.
Okay.
So this was the question, how do muscle relaxers used to relieve leg pain and foot cramp work for nocturnal leg cramps? Part 2 of that question, is there a best way to alleviate nocturnal leg cramps, spasms, other than standing up?
Right. Yeah, I wish I had the cure for nocturnal leg cramps. I have these myself, and they are horrible. And if somebody did come up with a cure, I think they'd be a very rich person. There was one wives' tale that I've heard on multiple occasions, and that wives' tale was if you put a bar of soap at the foot of your bed, and when you feel that cramp coming on, you reach out there with your big toe and you touch that bar of soap and it will go away. Now, do I think a bar of soap has anything to do with that? Absolutely not. But typically we're getting the cramps in our calf muscles. And typically we're like, oh, we got to stretch that out, right? So when we stretch it out, we're bringing our toe up towards our knee. When we're touching that bar of soap, we're doing the opposite. Experientially, if I feel that cramp just starting to come on and I reach down there and I try to touch it with my toe, I have aborted some. Other ones, once they're fully on, it doesn't work and I've had to get out of bed and walk around and then they go away. There's some hydroxychloroquine. There's a couple other things that are kind of out there, but typically the leg cramps are managed by the primary care doctor and not me. So that's where I would start.